Good morning, afternoon, evening, everyone, and welcome to another WFPICCS Respiratory Chapter webinar. We have an exciting topic today on PEEP, prone, and lung recruitment in children. We have a couple of excellent guests, and I'd like to begin by introducing our team. Milind Jambaji is the head of PICU and Emergency Services at Ankara Hospital for Women and Children in Pune, India. We have our friend, Dr. Farhan Shekhar, who's a lead pediatric intensivist at Rainbow Children's in Hyderabad. Dr. Abdul Rahman Al Dathan is a pediatric critical care consultant at Ahmadi Hospital in Kuwait. My name is Michael Canary, and I'm a PICU doctor at Yale New Haven Children's Hospital. We'd like to encourage you, if you haven't done so already, to consider registering early for the upcoming World Conference in Melbourne at the end of September. And I think that I'm not sure if the early registration period is up, but we encourage you to take a look at that and participate. And here's the link if you haven't seen it already. But we're really excited to have you here today. And I think we would encourage you to jot down questions and save them. And we're hoping we have a very fruitful discussion on a very interesting topic that, of course, is of practical interest to all of us. So I'm going to turn this over to my colleague, Dr. Abdur Rahman, to introduce our distinguished guests today. Thank you so much.
Thank you, Michael. So without further ado, I'll introduce our first expert speaker, Dr. Robi. So Professor Robi Khemani is an attending physician in the Pediatric Intensive Care at Children's Hospital of Los Angeles. He's the Vice Chair of Research for the Department of Anesthesia and Critical Care Medicine and Professor of Pediatric Clinical Scholar at University of Southern California. His research and education programs focus on respiratory disease in critically ill children, particularly as it relates to mechanical ventilation and acute respiratory distress. So his work is funded by several grants from the National Institute of Health and Foundation. He has leadership positions in several international research organizations in pediatric critical care and has led initiative to develop international clinical practice guidelines for children with acute respiratory failure. Our second guest faculty is Dr. Shekhar. Professor Shekhar is a professor of critical care medicine and pediatric and medical director of respiratory care service at University of Pittsburgh Medical Center. He has completed his medical training at the Jawaharlal Institute of Postgraduate Medical Education and Research in India, followed by pediatric residency at University of Medicine and Dentistry of New Jersey, and the fellowship in pediatric critical care at the University of Pittsburgh Medical Center. His clinical and academic work has focused extensively on respiratory care in critically ill infants, and the academic work on children, particularly mechanical ventilation, ventilatory weaning, extubation readiness, and pulmonary physiology. He's one of the brilliant mentors that you're going to come across, and it's an honor to have both of you here. So without further ado, Dr. Robi, the mic is all yours.
Okay, hello everybody. Let me just share my screen here and make
Hello everyone. Before Dr. Robbie could start, a request to everyone, please put yourselves on mute, and we will have the questions at the end in the Q&A session. Make sure your gadgets are on mute.
Okay, everybody hear me okay? Is that better now?
Yep.
Yes,
Yeah.
sir.
Okay, great. And slides look correct, right?
Yep.
Yes, sir.
All right, wonderful. So it's really a pleasure to be here today and to talk about a topic that I think, yes, has a lot of clinical relevance for us as we're taking care of our children in the ICU about PEEP, prone, and specifically lung recruitment. I'll begin by saying I have no specific disclosures that are really relevant for this talk. A lot of my work has been supported by grants from foundations and the National Institutes of Health. So the concept here today that we're going to talk about, right, is this idea of risk of ventilating patients at low lung volume, that particularly for a lot of disease conditions that we encounter like ARDS, there's a lot of inhomogeneity in the lung. And when we ventilate patients where lung volume may be particularly low, right, we have this risk of recruitment and de-recruitment injury during tidal ventilation. And this ties back to the sort of fundamental concept that we think about in acute respiratory distress syndrome that Dr. Gattinoni really coined many years ago of this baby lung, right? That there is an overall reduction in the compliance of the lung that primarily originates from this gasless compartment, right? But the regional compliance is preserved in that baby lung area. And conceptually, right, the relationship that we see between the compliance of the lung as well as the pulmonary vascular resistance is dependent upon the end expiratory lung volume. That if we have a low end expiratory lung volume, the compliance is worse, the resistance is higher. If we have a too high of an end expiratory lung volume, right, the resistance is high and the compliance is poor. And so as we try to manage these patients with ARDS, our goal is not to ventilate them at a low lung volume, but to try to recruit the lung, right, with sort of potentially stepwise increases in airway pressure to keep the lung open as we are ventilating them. And there have been a lot of efforts over the years to come up with strategies on how to do this. And I'll use this as an illustrative example of how this concept is great, but if we're not careful with this concept, we in fact might do more harm than good. And this was the ART trial. The ART trial was the alveolar recruitment and PEEP titration trial in adult patients with ARDS, where they used a recruitment maneuver that was relatively aggressive to try to open the lung. And you can see here a stepwise recruitment maneuver starting with a PEEP of 25, a delta P of 15, increasing the PEEP step by 5 to a recruitment step of 50 over 35, followed by subsequential decremental PEEP titration. So they would drop the PEEP, find the point of best compliance, re-recruit the lung, go back up to 50 over 35, and then maintain ventilation in the point where PEEP was deemed to be optimal based upon respiratory system compliance. And what happened? Those patients did worse, right? Patients that were managed with that strategy compared to just an empiric low PEEP FiO2 table, oxygenation strategy for PEEP management, did worse. And as you look to why, right, there were many more incidents of barotrauma, right, higher rates of pneumothoraces, and many of these recruitment maneuvers had to be stopped prematurely because of hemodynamic compromise in that process. So what this highlights to me is that while this may have strong physiologic basis, and we're going to talk a lot about that throughout this talk, we have to be very careful in how we apply these principles. And we really need to evaluate what types of patients are likely to respond to things like recruitment maneuvers or large increases in PEEP, i.e. get some sort of assessment of the recruitability of that patient. Now, there is still, I think, a lot of debate about how we should be titrating PEEP, right? What are the best methods for PEEP titration? And I'm going to spend a lot of time talking about this a little bit. And my fundamental premise is that although there are lots of different methods, we really should be thinking about tying the method that we choose for PEEP titration to the physiologic state of the patient or the guiding physiology that's compromising that particular patient. We'll talk a little bit about that throughout the course of the talk. And then the sort of last area that I think is really relevant in ARDS in particular is we're increasingly learning that ARDS is not one size fits all. There is a lot of heterogeneity in ARDS and lots of different factors that might predict a therapeutic response to an intervention such as PEEP or such as lung recruitment, for example. And we need to be thinking about those potential sources of heterogeneity as we approach the patients that we take care of. So that's the sort of brief outline of what we're going to talk about today. So let's start with this individualized PEEP titration methods. And I'm going to focus on the first four because I think they have the most clear evidence, although dead space is certainly a very interesting topic area and one that I use intermittently. And so oxygenation, right? This is probably the tried and true method that we think about in terms of trying to optimize PEEP. There is a large amount of adult data looking at oxygenation, starting first with this concept of a PEEP FiO2 table. That is, that based upon the FiO2 that the patient is on, you have a combination of PEEP values that you might say could be used for that particular patient. Adult studies have compared, for example, the low PEEP FiO2 table, which might be a PEEP of 10 with an FiO2 of 0.6, to the high PEEP FiO2 table, for example, with a FiO2 of 0.6 and the PEEP of 20, demonstrating that there may be some subpopulations where the high PEEP FiO2 table, for example, might be preferred to the low PEEP FiO2 table. In pediatrics, we don't have RCT data here that are specifically evaluating the PEEP FiO2 table, but we have a number now of observational studies. This was one of the early ones that we did, but this has, I think, been recreated in multiple cohorts now that highlights this concept that regardless of the initial oxygenation severity of the patient, that patients that are generally managed with PEEP levels that fall below that low PEEP FiO2 table do worse. And this is true regardless of initial oxygenation and after controlling for a number of confounding variables. This is observational data, right? So there might be a lot of confounding in this data. So we do our best to control for variables that might influence PEEP selection as well as might influence outcome. Yet there still seems to be a consistent signal that we should be using PEEP levels at least in line with the low PEEP FiO2 table. And that's, of course, what underscores the only strong recommendation we had from PALIC2, which was that PEEP levels should be maintained typically at or above, what you would be seeing with the low PEEP FiO2 table from the ARDS network protocol. And here's, that example. So 50% or 0.5 FiO2, that's a PEEP level somewhere between 8 and 10. But what I think is also important to remember, which we highlighted in PALIC2 and which is true in our clinical practice, right, is that this is probably not the only way to set PEEP, nor should it be, right? This might be a guiding way for us to start to say what's the right combination of PEEP and FiO2 to begin with. But we should be adjusting PEEP levels to evaluate and make sure that we're staying within other lung protective limits, i.e. that the driving pressure and the plateau pressure is in the appropriate lung protective limit, and adjustments to PEEP that alter respiratory system compliance, as an example, and improve respiratory system compliance might allow us to stay within these plateau and driving pressure limits. Hence, looking at and evaluating hemodynamics as well as compliance measured under static conditions, which we'll also talk a little bit about, is also really important as we think about PEEP titration. And so that's what leads, I think, to the next sort of main method of PEEP titration that is increasingly being used, I would say, in clinical practice, which is this idea of trying to titrate PEEP to the point at which we get optimal compliance for the patient, because that will allow us to use the lowest inspiratory pressure to achieve the tidal volume that we would like, allows us to perhaps be more compliant with the plateau pressure and driving pressure limits that are recommended. And conceptually, right, when we are thinking about using compliance as the method to guide PEEP titration, it's important that we first recruit the lung. Well, why is that, right? Because remember the pressure volume relationship, especially for patients with ARDS, there's some hysteresis in this relationship. That is that the way the pressure volume curve is and the compliance as I am inflating the lung, right, is lower than what it might be as I am deflating the lung, i.e. if I can recruit the lung and manage the patient on
राम
the
brother मेरे headphones का box है क्या?
and manage the patient on the deflation limb of the pressure volume curve, right, then this is allows me to operate under better mechanical situations. The compliance is better. I can use a lower overall pressure, for example, to achieve the tidal volume. So hence this idea that we should stepwise increase the PEEP.
Dr. Robbie, you have gone on mute. Sorry.
Yeah. You muted, Robbie.
Oh, I've gone on mute. I wonder how that happened. Okay. Sorry about that. I'll start over with this slide. Did you hear the previous slide? Should I just start with this slide? Yeah?
This slide, please.
Okay, excellent. Sorry. I apologize about that. I must have hit a button I didn't mean to hit. So, so what's the idea here, right? So the idea of when we're trying to titrate PEEP to optimize lung compliance, we have to go back to the concept that there is hysteresis in the lung, particularly for patients with ARDS that might have relative inhomogeneity in their lung injury. And what that means, of course, right, is that the pressure volume relationship as I am inflating the lung, right, is different than the pressure volume relationship of as I am coming down on the deflation limb of the lung, i.e., it takes more to open the lung than it is to keep it open, as an example. So the concept of using a recruitment maneuver is I want to get to this sort of total lung capacity and then start coming down, right? Find the point of best compliance here and keep ventilating my patient on the deflation limb of the pressure volume curve, not on the inflation limb, because this is better sort of, respiratory mechanics for the patient there. And that's the idea of using some sort of recruitment maneuver, such as a stepwise increase in PEEP to get to close to total lung capacity, followed by the decremental PEEP titration to find the PEEP of best compliance. Now, I might go below the PEEP of best compliance and de-recruit the lung in that process. So then we do a re-recruitment step back up to the PEEP of total, we're closer to total lung capacity, and then maintain at the PEEP level for overall ventilation. And as I alluded to before, this is the type of maneuver that was done in the ART trial with a very aggressive recruitment maneuver. So 25, 30, 35. So we're talking about 50 over 35, excuse me. Followed by the decremental PEEP titration and re-recruitment. And as alluded to, this caused some harm. So how can we prevent this, right? So conceptually, this makes sense that we should be trying to ventilate patients on the deflation limb. We should do some recruitment. We should try to find that point of best compliance on that deflation limb. But what can the consequence be? Well, the consequence can be, particularly if you have a patient that does not have recruitable lung and you're continuing to sort of march up that inspiratory pressure without paying attention to potential consequences, right? You may induce significant hemodynamic compromise in that patient. You may cause a pneumothorax or stress on the lung in that particular situation. So there are a number of ways to try to get some assessment of recruitability of the lung. And this is a lot of focus in the adult literature right now to have a guide that says, okay, this patient has recruitability. One of the methods, for example, might be the recruitment to inflation ratio, where you look at two different steps, for example, of PEEP and the relative gain in lung volume that you may see between those two different steps of PEEP. But what I would contend is you can even do this more simply and just be very cautious with your recruitment maneuvers. That aggressive recruitment maneuvers should really not be done, I would say, almost in any patient, but certainly in patients without a clear evidence that they're recruiting. And so I'll tell you my approach, right? So this is how I do my recruitment maneuvers with decremental PEEP titration to try to find that balance point. So first, it's really important that the patient is passive, right? They should be paralyzed. They generally do not tolerate large increases in PEEP, especially if you are over distending the lung. They have a drive to breathe. They're going to continue to try to breathe and potentially cause injury. So this is why it's important that these patients are paralyzed. That you have very close hemodynamic monitoring of these patients during this process. So continuous telemetry, if you have an arterial line, wonderful. If you don't have an arterial line, very frequent non-invasive blood pressure cuffs. And I do recruitment steps in sizes of 2. So not 5, like was done in the ART trial, but I go up by PEEP steps of 2 to a PEEP of either 20 or 24, depending on who the patient is. If I think the patient, for example, is a very obese patient, I might choose a higher PEEP level to go to for the to get to recruit the lung. If I have a non-obese patient, for example, then I might go lower. And importantly, as you're going up, right, you keep a set pressure. So I use a pressure control mode with a delta pressure of 15. As you are going up, you want to very closely watch the heart rate, the blood pressure, or monitor for any fall in oxygenation. And if that happens, you abort at that step and immediately start to come down with the decremental PEEP titration, again, down in steps of 2, where I measure the compliance at each of those steps and do a plateau pressure to calculate the driving pressure, because what's important at those steps is calculating the static compliance, not just the dynamic compliance, right? So remember the difference between the static and dynamic compliance. A static compliance is the tidal volume over the driving pressure. Sorry, I don't know where that pointer is coming from. It's like a ghost pointer, which is the plateau pressure minus the PEEP, okay, compared to the dynamic compliance, which is in a passive patient, the tidal volume over the peak inspiratory pressure minus the PEEP. I make the point about the passive patient because remember the patient can be a part of this process. And this relates back, of course, to the equation of motion of the respiratory system, right? That the pressure that is required in the system can come from both the ventilator and the patient's effort, the patient effort being PMUSC. And it has elastic components, which is what the alveoli are seeing based upon the elastance in the tidal volume, and resistive components, i.e. the airway components based on resistance and flow. So when I do an inspiratory hold maneuver, right, i.e. a plateau pressure maneuver, flow goes to 0 during that process. So the resistive component is removed. And what I am directly measuring is really what the alveoli are seeing, i.e. that static component, which is what the real driver is as we think about the risk for lung injury. Now, I'll make the point that during the recruitment maneuver and the decremental PEEP titration, it's important that patients are passive, i.e. they're under neuromuscular blockade. But even in circumstances where they are not, and let's say I am just doing some PEEP titration, it's important to measure the static-based compliance, because if you do an inspiratory hold and a plateau pressure under most circumstances, right, you can actually get the true assessment of how much pressure is in that system. This is why it's important to measure the plateau pressure on all patients, regardless of whether or not they have respiratory effort. If we think about a paralyzed patient or a patient with low effort, then what we see typically is the situation on the bottom left, where the plateau pressure is similar to or slightly lower than the peak inspiratory pressure, depending on how you have set the inspiratory time, for example, on the ventilator. But when patients have respiratory effort, right, then they are using some of that effort, right, to contribute to the tidal volume. When I do an inspiratory hold maneuver, as long as that patient becomes passive at the end of inspiration, which most do, at least 70 or 75% of patients will tolerate this inspiratory hold maneuver, even when they're breathing spontaneously, then you get that reflection of what the total pressure is in the system, i.e. that total driving pressure or total plateau pressure in the system. And here's an example on pressure support, where we have a patient that's breathing spontaneously. Here's the esophageal pressure catheter. You see with each breath, there is significant spontaneous effort. We do the inspiratory hold, and you see this rise in the plateau pressure above the peak pressure. And this is what reflects the amount of effort, for example, that the patient is using to pull the tidal volume, i.e. this is the total pressure in the system, the driving pressure to achieve that tidal volume. So we really should be measuring the plateau pressure on all of our ventilated patients, because the plateau pressure is not the same as the peak pressure. In passive patients or patients with minimal effort, it will be similar to or below the peak pressure. In active patients, it can be higher or the same or lower than the peak pressure, depending on how much effort the patient has. So let's try to tie this together in a scenario, okay? So I have a 3-year-old patient that's got viral pneumonia and ARDS, is currently being ventilated in an assist control mode in PRVC. Tidal volume is set at 7 mLs per kilo. PEEP is 8, FiO2 is 0.7. Peak pressure is 28, plateau pressure is 27. This patient is under neuromuscular blockade. As we look to the PEEP FiO2 table as a guide, it would say on 0.7 FiO2, this patient should be on somewhere between 10 and 14 of PEEP. This is a lower PEEP, for example, than we have set in our usual practice here. So this is where let's try the recruitment maneuver, right? So we do a recruitment maneuver followed by decremental PEEP titration on this patient. And what's important is I don't pay attention to the compliance as I'm doing the recruitment maneuver. The point of the recruitment maneuver is to open the lung. So the goal there is just to make sure that oxygenation is improving and the hemodynamics are tolerating that, right? So we see that during the recruitment maneuver, in fact, the oxygenation is improving. And then as we start to come down, right, PEEP of 16, PEEP of 14, PEEP of 12, PEEP of 10, what we notice, in fact, is that the static compliance is improving, okay? And so this patient would have recruitable lung. There was clear recruitability to that lung, and the PEEP of optimal compliance in this particular patient seems to be around a PEEP of 12. In fact, if I keep the same tidal volume of 7 mLs per kilo for this particular patient, I in fact can keep both my plateau pressure and driving pressure in what we would deem an acceptable range. So this seems sort of optimal for this patient with recruitable lung. They had a favorable response to the recruitment maneuver, and PEEP seems to matter. PEEP seems to improve their compliance. Take the same scenario, exact same case, whereas this is what you start to see in the recruitment maneuver, right? As we go up, maybe we see minimal change or increase in oxygenation of that patient, but probably most importantly, as we go up, the lung compliance has dropped, and as we drop it, right, there is no real gain in terms of lung compliance over where you started, and there's in fact minimal change in the lung compliance as you alter the PEEP. So this is a patient that does not really appear to have much recruitable lung. And in fact, I would say at where we have set things right now, let's say we keep them at a PEEP of 8, they're a pretty dangerous point, probably in driving pressure, 19 to 20 as an example. And so this is the patient where, in fact, we should not be continuing to escalate PEEP. And if we want to stay in the lung protective targets that are recommended for inspiratory pressure, we actually probably should be dropping the tidal volume on this patient at that point. Okay, so let's switch gears. So that was about recruitment maneuver and compliance. Let's talk about another method, esophageal pressure. So conceptually, where does this come from? Remember that the esophageal pressure is a surrogate for pleural pressure. And as we think about why the pleural pressure is important, right, at normal functional residual capacity, the pleural pressure is slightly negative. It is the balance point between the chest wall and the alveoli, right? Without the chest wall in place, right, we would have the alveoli collapse, right? So, and without the chest wall in place, right, without pleural pressure, the negative pleural pressure in place, the chest wall may expand. And so it's really that balance between the recoil forces of the lung and chest wall on that space. And when we inflate the lung, right, we inflate the lung by generating a positive transpulmonary pressure. How do we do that? As we're breathing spontaneously, right, not on a ventilator, we generate a positive transpulmonary pressure. Remember, the transpulmonary pressure is the alveolar pressure minus the pleural pressure. So we do that by lowering the pleural pressure, right? So if I start with an alveolar pressure of 0, I lower my pleural pressure, I generate a positive transpulmonary pressure. What happens to a passive patient on a ventilator? Passive patient on a ventilator, we still generate a positive transpulmonary pressure, but we do that by providing positive pressure into the alveoli. Some of that pressure gets dissipated into the pleural space, but the net effect is still more in the alveolar space relative to the pleural space to generate that positive transpulmonary pressure to, in fact, inflate the lung. Now, what happens when we have circumstances like this, right? We have obesity as an example, where there may be increases in baseline pleural pressure, right? Well, then in order to generate that positive transpulmonary pressure, if the pleural pressure is elevated to start with, we need more alveolar pressure, right? We need more pressure provided into the alveoli in a passive patient, right, to generate that positive transpulmonary pressure. And this is the concept of trying to use esophageal pressure to guide PEEP titration to try to normalize the transpulmonary pressure, with the idea being that since we need a positive transpulmonary pressure for the lung to inflate, can we apply PEEP to keep the transpulmonary pressure positive at end expiration to prevent collapse of the lung, right? So that when I apply that inspiratory pressure, I am actually inflating the lung. Remember, under normal circumstances, again, transpulmonary pressure is the alveolar pressure minus the pleural pressure. So under normal circumstances in spontaneously breathing patients, our transpulmonary pressure is slightly positive at end expiration, +3. This makes sense. This is what allows the alveoli to stay open and not be collapsed. But if I have a circumstance of increased pleural pressure from obesity, as an example, where I have a pleural pressure of +10 instead of -3, now my transpulmonary pressure at end expiration is negative, and that alveoli is likely to collapse. But conceptually, we can counter this, right, by applying PEEP. And this is just an illustrative example where this is, the ambu bag inside is meant to reflect the alveoli, and the chamber here is meant to reflect the pleural pressure. What you can see, or maybe you can't see, I apologize if you can't, is that this 6, 12, and 20 represents the pleural pressure, and that if we apply PEEP here in the bag, equivalent to this pleural pressure, I can keep this ambu bag, i.e. the alveoli, open and prevent it from collapsing. And that's the idea of particularly using transpulmonary pressure in obese patients, as an example. And here's an illustrative example that we've had with an obese adolescent whose body mass index was 45 with ARDS, initially managed, right after ventilation on a PEEP of 5, placed an esophageal catheter, and the PES PEEP, right, the end expiratory esophageal pressure, the reflection of the pleural pressure, was +20. So this patient had a transpulmonary pressure at end exhalation of -15. Not surprising that the lungs look collapsed. If we increase the PEEP on that patient, PEEP up to 24, now the PES PEEP has gone up to 24 slightly, because remember, some of the pressure that you apply at the airway and alveoli gets transmitted to the pleural space. But now this results in a transpulmonary pressure of 0, and in fact, the lung is able to be opened. And there's a lot of animal data to support this conceptually, right? This idea that if we target a transpulmonary pressure of above 0 at the end of expiration, that things may be better, right? Things like intratidal recruitment and de-recruitment from this animal model of ARDS, that at transpulmonary pressures greater than +2 is when you start to have much, much less tidal recruitment, de-recruitment injury. This is another animal model that simulated obesity and looks at electrical impedance tomography. I'm going to talk a little bit about that next, but I'll introduce the concept here. So with electrical impedance tomography, you're looking at this idea of what lung units might be collapsed relative to the lung units that might be overdistended. And there's a concept, which again we'll talk about in a minute, of trying to find a balance point between collapse and overdistension. And so in this non-obese swine model, the balance point, i.e. the crossing point of the two, happens at a PEEP of about 7, okay? Non-obese pig with ARDS there. The transpulmonary pressure, where this balance occurs, is +1. Take the obese model, obese swine model, you note that the curve is shifted to the left, right, of the balance point between collapse and overdistension. That is occurring at a PEEP level close to 11, but interestingly, right, the transpulmonary pressure is still the same between 1 and 2. So this is where that concept comes from, that if we target an end expiratory transpulmonary pressure slightly positive, we at least are overcoming the effect of the chest wall, and we'll be able to keep the lung open. What's the evidence for this? So the adult data, the first EpiVent trial, which was done in the mid-2000s, compared an esophageal pressure guided method that was always targeting a positive transpulmonary pressure, but in fact could go to as high as about +6 or +8, depending on how much hypoxemia the patient had, compared to the low PEEP FiO2 table in these adult patients. Now note, a lot of these adult patients were actually quite obese. in this initial trial by Danny Telmore. And you'll notice that PEEP was significantly higher in the esophageal pressure group compared to the conventional ventilation group. PEEP levels on average of 18 to 20 compared to closer to 10 in the conventional ventilation group. And that resulted in improvements in PF ratio, improvements in respiratory system compliance, and there was certainly a signal for improvements in clinical outcome, although it was not statistically significant in the first EPIVENT trial. So that led to the EPIVENT 2 trial, again in adult patients with ARDS. This was multi-center, but instead of the low PEEP FiO2 table as the comparator group, they used the high PEEP FiO2 table as the comparator group. And they got almost no separation on average in terms of end expiratory transpulmonary pressure. They were near zero for both groups, the esophageal pressure group and the high PEEP FiO2 table group. And that translated to no clear difference in the outcomes like survival or even ventilator-free days. Now, what's emerged after that in post-hoc analysis is that there's probably some specific individual patient variation that's important here. That patients that have lower initial severity of illness were in fact more benefited from the esophageal pressure-guided PEEP strategy, but that across all patients, those that achieved and consistently were managed with the transpulmonary pressure close to zero, plus or minus 2, are the ones that had the best outcome. That patients with end expiratory transpulmonary pressures below zero did worse, and those that were significantly above zero also did worse. Do we have any pediatric data? Well, not a lot, but we have some observational data that's emerging. This was a nice study by Dr. Sachdev's group, actually from India, which used the Avia ventilator as the method to titrate transpulmonary pressure. And they compared usual care in a small cohort to those that were managed with transpulmonary pressure guided therapy targeting a positive transpulmonary pressure. And what you'll notice is that at a sort of initial evaluation or randomization, right, patients were similar in terms of oxygenation. Maybe even oxygenation was a little bit worse in the transpulmonary pressure group. But over time, the transpulmonary pressure group achieved better oxygenation compared to what would be done in usual care without the transpulmonary pressure. Now, we recently completed our REDVENT clinical trial, and the REDVENT clinical trial did not use esophageal pressure for PEEP titration, but it used esophageal pressure to guide changes to inspiratory pressure to target diaphragm protective ventilation. But the corollary to this, or the benefit of this, is we have esophageal pressure measurements on all patients in the trial every day. And what we saw is that in this cohort of pediatric ARDS patients, about 250, in fact, the end expiratory transpulmonary pressure was close to zero for most of these patients. Median PEEP was around 10, and median PES PEEP was also near 10. Now, when we look at outcome, okay, this is ventilator-free days, the primary outcome. As PEEP increases, there are fewer ventilator-free days. That makes sense. That's been well established that PEEP is a surrogate for severity of illness. Higher the PEEP, fewer ventilator-free days. Similar trend is actually seen with PES PEEP, but when looking at end expiratory transpulmonary pressure, there does not seem to be a clear relationship between end expiratory transpulmonary pressure and more ventilator-free days. And certainly that target of -2 to 2 does not seem to necessarily be better than either of the other two groups. Same thing when we look at mortality as the outcome, that as PEEP is increased, mortality increases, but end expiratory transpulmonary pressure does not seem to have a clear relationship with mortality. And when we look at the outcome of length of ventilation in survivors, in fact, those with the end expiratory transpulmonary pressure near zero, in fact, had longer length of ventilation. So the point of this is to highlight that esophageal pressure, I think, is a very attractive method conceptually and physiologically, but translating this to a protocol that we use for all of our patients to guide management, we don't have, I think, the evidence yet to be jumping to that step. And so we can talk about that perhaps in the discussion about where I think we need to go next with esophageal pressure-based PEEP titration in pediatric patients. But the data does not, I think, support us using this routinely yet. Okay, the next method I'll just mention is looking at electrical impedance tomography. And electrical impedance tomography is an attractive conceptual method, right? What it's trying to do is look at relative changes in impedance by using this belt or these stickers. Most have now gone to belts that go around the chest to evaluate regional areas of ventilation, right? And this is particularly important in ARDS because our lung injury is not homogeneous. If we have a homogeneous lung, right, then as we apply pressure into that lung, all of the lung expands relatively homogeneously. That's not entirely true under health, but conceptually, that's the idea. When we have these areas of collapse, right, then what happens as we apply that inspiratory pressure is that you may get relatively more increases in the areas around the collapse because that area of collapse does not open, in fact. So this regional area is subject to higher amounts of strain, for example, on the lung. And so this is what underscores using this idea of EIT to titrate PEEP, because you're trying to balance the areas of collapse with areas of overdistension, which may occur as I increase the PEEP. So typically what's done for EIT-guided PEEP is we start with the recruitment maneuver, and then you adjust the PEEP through a decremental PEEP titration using EIT to create this curve of relative overdistension versus collapse. At the highest PEEP level, which is meant to represent recruitment of the lung, there is no collapse, right? And there's some amount of overdistension that's present. As I drop the PEEP, the amount of collapse will increase and the amount of overdistension will decrease. And the idea is that you may try to find the balance point between the two and say, okay, this might be the point of titration that we should use for PEEP because it's balancing regional differences and hyperdistension and collapse. Now, that might not be the exact same PEEP point for where compliance is best. That might not be the exact same PEEP point from where FiO2 or oxygenation is best. But there's an advantage here of giving you some regional information. Now, the data on this, as far as outcomes, is still very limited. Lots of physiologic studies that I would say are ongoing both in adults and in children, and there are even some small randomized trials that are ongoing in adults. There's still a lot of, I think, unanswered questions if the crossing point PEEP is really the best target for everybody, and I don't know the answer to that, but fundamentally, this technique is very promising for us to understand the regional differences in stress and strain in a non-homogeneous lung, and that's why there's a lot of advantage. The last method I'm just going to mention quickly is dead space, and as we think about oxygenation, right, as a marker for PEEP titration, as you increase PEEP, inevitably, until you get to a point of very significant overdistension, you're likely going to see increases in SpO2. So the oxygenation as your marker does not really tell you enough information about overdistension. But it might be that if you use the oxygenation in conjunction with a dead space measure, you might be able to find this balance point between overdistension and recruitment. Because remember, when we think about dead space, right? Dead space is an area that is receiving ventilation, but not perfusion. In contrast to shunt, right? An area that is not receiving ventilation, but is receiving perfusion. And so as we go to this curve that we started the talk with, as I overdistend, and if I might go above, optimal functional residual capacity, pulmonary perfusion is going to be compromised. As pulmonary perfusion is compromised, the dead space fraction increases. And so you can use the VDVT measure, right, to sort of recreate that same curve here that sort of overlays this PBR curve as an example to find the point where perhaps pulmonary perfusion might be more optimal. Okay, so I'm going to just finish quickly here by starting to talk about prone. And prone positioning, this is data from the PARTY study. Globally, in all ARDS patients that were included in the PARTY study, prone is used in about 10% of patients. Now, this number is actually considerably higher when you look at severe patients and when you look at developing world in particular. Prone is used a lot more frequently in the developing world compared to in the United States, as an example. The adult literature seems to support prone positioning as beneficial, particularly when combined with good lung protective ventilation. And that was really very heavily driven by the Guerin study in severe ARDS patients, the French study, which highlighted a clear survival benefit in the prone group compared to supine for those that had pretty significant ARDS. The mean PF ratio was 100 in that group. Our pediatric RCT up until now, right, has been the initial prone study done by Martha Curley now almost 20 years ago, or over 20 years ago, which really showed no difference in outcome in a relatively smaller cohort, 50 patients in each group, of more moderate ARDS patients, pediatric patients. But there's a lot of really good physiology for why prone positioning might be helpful in ARDS. And it could be related to changes in regional distribution of ventilation and perfusion, i.e., independent of its effect on lung injury, it actually might improve VQ matching, so improve oxygenation, improve CO2 clearance that allow you to be more lung protective, for example, with FiO2 prescription or PEEP prescription. But it also improves the both cephalocaudal and dorsoventral distribution of regional pleural pressures. And we'll talk a little bit about that. And that might improve recruitment, but it also reduces inequalities in regional time constants, right? So the regional nature of ARDS and the heterogeneity that we alluded to become less relevant when the patient's in the prone position because you normalize these inequalities to get potentially more homogeneous distribution of gas. So if we go back to this example of that non-recruitable patient, right, that we talked about earlier, where we said, okay, well, let's lower the tidal volume. This might be a patient that we should prone, right? And if we look at PALIC, insufficient data to support or refute the use of prone positioning in patients with ARDS, but that we might want to consider it in patients that have hypoxemia that's not responding to other interventions, i.e. I'm trying to recruit with PEEP and it does not seem to be working, for example, in this patient. And this highlights that point nicely, I think, because by proning somebody, sometimes you are able to really increase the size of the baby lung even more than you're able to do, for example, with increases in PEEP. And here's the example of a patient from supine to prone. You can see relatively larger increases in sort of size of areas that could be ventilated. You take a different patient here in this example, you try to recruit them with PEEP alone, and you may only get marginal increases in the size of the baby lung. Now, why could this be? Well, I think this is really nice work that Bhushan Katira has done in animals that highlights that the pleural pressure gradient, both ventral, dorsal, also it's true cephalocaudal, is much more homogeneous across PEEP when patients are in the prone positioning. So if the patient is in the supine position and is on low PEEP, then from the ventral to the dorsal portion of the lung, you may have a very large swing in pleural pressure, up to 8 centimeters of water. That same patient that's in prone at that PEEP level, in fact, the pleural pressure gradient is much more homogeneous. And so what this translates to, right, is differences, less stark differences in tidal volume and ventilation based upon PEEP, right? In the prone position, you have more homogeneous ventilation compared to in the supine position, where you may get pretty significant regional differences in ventilation based upon the PEEP level that you've chosen. Now, that's a patient that might have good recruitability, but it may also be helpful in patients that do not have a lot of recruitability to their lung, because as you turn a patient prone, and here's an example here of a non-recruiter, that as you turn that patient prone, right, you may have a significant improvement in oxygenation and without necessarily a large improvement in respiratory system compliance, simply from ventilation perfusion matching. And we focus a lot on oxygenation response, and I think that's an important response, but maybe the more important response could be the CO2 response. And this goes back to that concept about dead space, that if you, for example, this is a study by Gattinoni in adult patients, that if you looked at, they did not change the ventilator settings when turning prone, right? And it was a volume control mode, so the minute ventilation was the same. And they looked at those that had an improvement in oxygenation. They looked at those that had an improvement in CO2, a reduction in CO2. When you look at the oxygenation, there was no difference in survival between responders and non-responders. But those that had an improvement in PCO2, which would be coming from a reduction in dead space, right, in fact, had better survival compared to the PCO2 non-responders. Now, the good news is we have answers coming soon, right? The PROSPECT study has been completed, the prone and oscillate 2x2 factorial design study in pediatric patients with moderate to severe ARDS. I think the design of that study will help us because it's overcoming the limitations of disease severity, which were seen in the initial trial. Also overcoming some limitations in the initial trial with very high rates of use of high frequency in both arms. And now high frequency use is going to be controlled as part of the PROSPECT trial. And hopefully there's enough physiologic data that we can sort of decouple why the potential benefits might or non-benefits might be seen with prone positioning by analyzing data out of PROSPECT. And I think they're hoping that we will hear results in the coming month or two. So I'll conclude by just talking a bit about heterogeneity, right? Remember that ARDS is a syndrome, right? This is a clinical syndrome where there's no clear definitive diagnostic test, right? And so our definitions are based upon clinical signs and symptoms, and our severity classifications are largely based on oxygenation. And oxygenation may not be the only answer, right? We have some rough guidance that have come out with PALIC to think about this concept that the adequacy of therapies may differ based upon severity of ARDS or severity of oxygenation. And clearly you're not going to likely be doing prone positioning in a patient with very mild degrees of ARDS, for example, although increasingly it's being studied in conditions like bronchiolitis and non-intubated patients as an example. So as we think about ARDS, there are many potential sources of heterogeneity that might influence outcome, or more importantly for this talk, treatment response, right? Things like the ARDS trigger, the biological pathway, i.e. the phenotype, is it an inflamed or non-inflamed patient, patterns and persistences of organ dysfunction, physiologic mechanisms, which I've talked a fair amount about with recruitability, but also things like respiratory drive, as well as comorbidities. And when I think about this list, as it applies to recruitment, PEEP, prone positioning, I think many of them are actually very relevant and very important. And I'll go through a few examples. Let's talk first about the ARDS trigger. This is data that's not published yet from our group, but it highlights that when we're thinking about recruitment, right, the idea is trying to increase the size of the baby lung, right? And so there, it's the idea that the mechanism of injury is related, or the mechanism of hypoxemia is related to intrapulmonary shunt. And what we've seen in our secondary analysis of the red band data is that, in fact, for patients that have viral-mediated disease, there's relatively more preservation of respiratory system compliance for the degree of oxygenation impairment. So it might be that these patients with severe hypoxemia and viral disease are not the ones that are going to have a high amount of recruitability to their lung injury, because their mechanism of hypoxemia is not coming from significant impairment in lung compliance and loss of end-expiratory lung volume. I think there is clear data from the adults that the biological pathway, i.e. degree of inflammation, is important for recruitability and PEEP management. What we saw in Carolyn Calfe's work is that patients in that hyperinflamed adult phenotype, when reanalyzing the high PEEP versus low PEEP strategies, the high PEEP strategies seemed to benefit those that were more inflamed. And the low PEEP strategy, or the high PEEP strategy, potentially harmed patients that in fact were not inflamed. So this is where mechanism there of inflammation might be really relevant. I've talked a lot about recruitability already, but I just want to make a point that I've spent a lot of time focusing on a paralyzed patient, This is also very relevant in patients that are not paralyzed, that are breathing spontaneously, and that PEEP management and recruitment might be very helpful, particularly to modulate very high respiratory effort. I'll just leave it there. I don't have too much time to go into this, but that's the teaser of the concept. And then the last area is in comorbidities, and we certainly know that immune suppression, for example, is a major comorbidity that influences outcomes. Also, certainly is likely to influence recruitability because the mechanisms of injury in these patients that may have been exposed to repeated injuries from conditioning regimens or other things, for example, as part of their cancer treatment or their bone marrow transplant conditioning, might have a major impact on the likelihood that they respond to things like prone positioning or PEEP management. And nutrition might be another really important and relevant variable here. This is, I think, a really fascinating observational study that came out of the PARDS Asia study, that the PEEP FiO2 table and management in line with the PEEP FiO2 table, we've classically thought of PEEP management being very important for patients that are overweight or obese. This, in fact, highlights that failure to even align with the low PEEP FiO2 table for the underweight patients may, in fact, be even more harmful. So highlighting this sort of misconception that PEEP might be even most important for the obese patient. It maybe is also really important using an adequate PEEP for the underweight patient. So I'll just conclude by saying that a sort of one-size-fits-all approach really to PEEP and recruitment management does not work. We really need to evaluate who is likely to respond, i.e. have some gauge of whether they're recruiting. We should be matching the PEEP method of titration to the guiding physiology. I have an obese patient, then perhaps esophageal pressure is my best method to use. So if I've got a patient with significant heterogeneity in lung disease, this is where EIT management might be most useful. Prone positioning is likely to have the most benefit in those that have recruitability, but it may also help gas exchange even in those without recruitable lung. And I think in the future, we really need to be exploring the sources of heterogeneity of treatment effect for both these PEEP and recruitment and prone approaches in our patients. Thank you very much.
Thank you so much, Dr. Robinder. You have kept all of us hooked since last 1 hour to your talk. What a fantastic talk. And I would like to congratulate and thank you for this excellent talk. And now, can I request Dr. Shekhar Venkatraman, sir, to kindly have his inputs and summarize the topic briefly in the next 5-10 minutes, sir.
Thank you for the invitation, Robbie. That was an absolutely fantastic talk. Enjoyed it very much because there are few people left in the world who are still interested in lung physiology, and I particularly think of Robbie's mentor as my Manasika guru in this area. So he and I think very much alike about bedside titration of respiratory care. It is customary to summarize something that somebody has said. I'm not going to do that. I think if somebody paid attention, Robbie was very clear about everything and every concept that he talked about. So I am not going to summarize anything that he said. Instead, if I can take some time, while he was talking, I created some slides. They are complementary to what Robbie has said. If it's okay, I can share the slides with you.
Okay. So you're able to, sir?
Yeah, 1 second.
Sure, sir.
I can share screen?
Yes, sir. We are not yet seeing, sir.
Can you see it? Okay.
Yes, sir.
So the title of the talk was how to use PEEP without bursting the lung, right? And he made a very good point about the balance between trying to open the lung versus already open lung that needs to be protected. So unfortunately, in this discussion of recruitment, we have actually forgotten the landmark article on setting the best PEEP. This was done by Suter at a time in the 70s, at a time when we used to place PA catheters. So we actually had measurements of cardiac output, shunt fraction, physiologic dead space measurement as PEEP was increased. So I'm just going to go through the slide just few minutes. So when you look at the middle panel, as the PEEP was increased, so best PEEP is whatever number for that particular patient that resulted in the best PO2 combined with the lowest shunt, combined with the best compliance, combined with the best oxygen transport, combined with the best reduction in physiologic dead space and improvement in compliance and no change in cardiac output. And the numbers to either side of the best PEEP are relative to that point. So it is not an absolute value. Each patient might have had a different PEEP level. But what is actually striking to me in this particular paper is, as you keep increasing the PEEP, look at what happens to the shunt fraction. Shunt fraction actually starts to go down. So one might actually think that if you're at +6 above the best PEEP and your oxygenation improved, that you have actually recruitment. Instead, what they showed was the compliance actually goes down. That means there is hyperinflation of the already open lung. And there is a reduction in cardiac output. Now, Dancer in the 80s showed with multiple inert gas technique, where they measured the ventilation perfusion relationships and actually showed that improvement in oxygenation in many of the ARDS patients was not due to recruitment, was actually due to a reduction in cardiac output and redistribution of blood flow. So to me, going through the literature, oxygenation is the least sensitive indicator that you have recruitment.
Absolutely.
Now, he talked about the reduction in PEEP after a recruitment maneuver. What I found at the bedside is actually, this is a very easy to do test. I like to see both during the inflation phase and the deflation phase to find out how much hysteresis I have. If I do the recruitment and only do on the deflation phase, I do not know how much hysteresis I have for that particular lung. For example, I have sort of rounded up the numbers, but these are all taken from real patients. Model 1 is a very recruitable patient, and model 3 is a totally unrecruitable patient. What you see is as you go up on the PEEP, and each step you wait till the tidal volumes kind of stabilize. It takes about 20 to 30 breaths to do that. What you see is as you go up, the tidal volumes actually improve. And on the way down, like Robbie explained, Dr. Khemani explained, the tidal volumes are actually much higher for the same pressure. So in this patient, the ideal PEEP would have been somewhere between 10 and 12, 10 or 12. And depending on their hemodynamic response, you can either choose 10 or 12. Now, the other end, we see no change in tidal volumes. And in fact, a reduction in tidal volume as you keep increasing the PEEP, and absolutely no hysteresis. So if I didn't do this, if I just did a recruitment and bring the PEEP down, I might think that the PEEP of 10 is actually a good number because the tidal volume is maintained at a PEEP of 10. But if I do both up and down, it tells me there is absolutely no hysteresis at a PEEP of 10 or PEEP of 8 or a PEEP of 6. So in fact, PEEP of 6 actually might be the best PEEP for this particular patient. And then probably most of our patients fall in between, not the really recruitable or the unrecruitable lung. The other thing that I have noticed clinically, but I've not been able to do enough measurements to actually publish, is actually the younger the patient, the less recruitable their lungs are for the same level of disease process that we call pediatric ARDS. Now, I just want to illustrate graphically, when you have a very recruitable lung, what happens inside the lung. Supposing you have a recruitable lung and most of the reason for hypoxemia is atelectasis with very little consolidation, most of the partially collapsed and atelectatic lungs are fully open when you apply PEEP, with very little hyperinflation of the already open lung. Now you have increased the surface area. Now you should see an improvement in compliance, improvement in ventilation, and an improvement in oxygenation. Now, the intermediately recruitable lung, there may be a lot of consolidated lungs that don't recruit. The atelectatic lungs are recruitable, and the partially collapsed lungs are recruitable, but there is a price to pay that the already open lungs are starting to get hyperinflated. So now I have a slide where I will explain that a little bit better. Now, when you were to measure compliance change, you may or may not see an improvement in compliance, depending on how much is recruited versus how much is hyperinflated. Now, the third group, clearly, there is absolutely nothing to be recruited. So the only thing that happens is hyperinflation of the already open lung, and the consolidated lungs don't actually open. Now, there are two harmful effects with this. One, the open lung can get hyperinflated and cause lung injury. And the second one, there is redistribution of blood flow away from the good lung, open lung, to the bad lung, and so your shunt fraction actually can get worse if you try to increase PEEP in a lung that is not recruitable. So this is a very interesting paper that I came across, that depending on the inflation pressure and the initial shape of the alveolus, they undergo different kinds of shape changes. So it is possible in injured lung to have an alveolus that is partially open, that is not entirely geometrically symmetrical. So I don't want to go into the details of this paper. It's a very interesting paper that actually shows you that within the alveolus itself, you can have variation in the point stress and strain. So it's possible that everything is being done correctly. You're protecting the lung with good pressures, good driving pressures, and still one of the alveolus may be exposed to an injurious ventilation. Now, if you don't have a recruitable lung and a very recruitable lung, the guidelines, the PALIC guidelines don't tell you anything about how to titrate FiO2. When I was a fellow, it was drilled into our head that oxygen toxicity is a very important criterion to consider at the bedside. So we were very active in trying to get the FiO2 down to at least 0.5, if not lower. But we don't do such a good job these days of reducing the FiO2. We seem happy when the saturations are greater than 92%, and the PaO2s are in the 80s and 90s. We had a restriction. We were only 88 to 92 until recently. This latest guidelines say that we can allow a little bit more generous SpO2 measurements. I think, in my opinion, that is allowing more oxygen toxicity. We'll see. We'll see what subsequent data shows over the next 5 to 10 years. But if you take the person who has non-recruitable lung, and let us say he has 30% shunt, you can safely get his FiO2 down to about 0.6 or 0.5 without actually sacrificing much in the terms of PaO2. This iso-shunt lines created by Nunn is a very, very good graph to use at the bedside to titrate FiO2 when you have very high levels of intrapulmonary shunt. Now, a couple of myths and concepts. There is a concept that once recruited, and that is the basis for a lot of the RCTs and recruitment maneuvers, it is possible to maintain the lung recruitment So we can set the pressures in the deflation limb of the PV circuit. That is what the RCTs teach you. That is what is also the basis behind some of the high frequency ventilation settings. It's not true. Once you recruit the lung, if you wait for a sufficient amount of time, there is actually going to be de-recruitment of that lung. So that is why animal studies have shown that periodic lung recruitment is necessary to maintain the lung volume when you have an injured lung. But we seem to think that once we do it and we set it, it should be the same for the next couple of days. It's not true. The next concept that I think is very, very important for us at the bedside, because this is the most common question that it gets asked of me in any of the meetings. One is, how certain am I about recruitment? If you have all three, improved compliance, improved ventilation, and oxygenation, then I would say you can be very certain that you have recruitment of the lung, either by PEEP or by the recruitment maneuver. If you only have oxygenation, I'm not at all certain that you have much recruitment of the lung. Now, can there be recruitment with no change in or worsening compliance? Like Dr. Khemani suggested, yes, it is the balance. So improvement in compliance of the recruited lung can be offset by hyperinflation of the already open lung, and hyperinflation causes a reduction in compliance. So depending on how much you recruit and how much you hyperinflate, you may see an improvement in compliance, or you may see actually a decrement in compliance. Can there be recruitment with no change or worsening ventilation? The same physiology applies in that aspect as well. Today, as it stands, imaging is the only reliable way to tell whether you have recruited the lung, but it is not possible to do CT scan like Gattinoni used to do. EIT holds a lot of promise at the bedside for pediatrics. Now, we also talk about what is a safe end alveolar pressure. Okay, this is sort of the traffic light. So if it is red light, don't go there more than 40 centimeters. You don't want to be there. Green light, the PALIC guidelines say less than 28, but I think it might be safer to operate much lower than minus 28. Remember, normal breathing doesn't get you in end alveolar pressure at 28. So even 28 is a very, very high pressure for a lung that is open. Thank you.
Thank you, sir. Thank you very much, sir. We've got lots of questions lined up, and we've got only, I think, 15-20 minutes. Dr. Milind, shall we start?
Yes, sir. Yes, sir.
If you don't mind, I would like
Yes,
Robbie to actually say if he agrees, disagrees, or comment on what I actually added to his stuff.
Sure, happy to respond, Shekhar. As always, you have insightful physiologically based comments that I've always appreciated over the years. And I think everything that you said, in fact, is congruent and aligns with what I said. It's adding detail, I think, in many of the areas. And I think the couple of key take-homes that I think you hit, that I alluded to, the oxygenation point, I think, is crucially important. That if you are only looking at oxygenation as your marker of improvement, i.e., that I make things better, you are not getting the entire story, because oxygen and to take that one step further, SpO2 is not oxygen delivery, right? And that's why even in the PALIC guidelines, the recommendation is measures of oxygen delivery, with that idea that if you overdistend and you decrease pulmonary perfusion, as an example, your net effect, even of increasing the SpO2, might be a drop in overall oxygen delivery. So I fully align and sort of reaffirm that particular point. I think those early papers that you highlighted, illustrate that concept well, that each patient has sort of an optimal PEEP, right? That is different potentially for each patient. And it is really only through multimodal effects, right? Looking at both oxygenation, dead space, compliance, that you can try to put those pieces together. I think one of the challenges that I struggle with still is sometimes you get different information from each. And how do you handle that, right? Those early physiologic experiments, I think, are also highly based upon the type of lung disease that the patient has. And based upon your point of how much recruitability versus not there may be, you may get different answer from those different methods, which is why I think practically when you're at the bedside, right, and you don't have all of them to choose from, you should be guiding that principle based upon what the major issue is that the patient has. So if the patient is a very obese patient, as an example, with more homogeneous lung disease, right, and the primary problem is from the chest wall, either esophageal pressure or compliance are probably going to give you the right answers there because it's relatively homogeneous. If you've got a patient with very inhomogeneous lung disease, right, and there was a question in the chat about, what do you do with one lung is very severely impaired and the other lung is relatively preserved, as an example. This is where having that concept that the global measures of compliance, as an example, may not fully reflect what's the optimal thing to do for that patient, where something like EIT, for example, might be very important there.
There is another point I wanted to make related to your esophageal pressure measurement for the transpulmonary pressure. It is being increasingly recognized in the adult world that there are two forms of response to PEEP. One is the airways can be collapsed due to the weight of the organs in the dependent area. It can be from the obesity or it can be from the lung itself. Now, that collapse, all that you need is to exceed the critical opening pressure for that particular collapsed airway, and then that lung is completely open. And that may actually be happening in many patients who are prone, because that weight is taken away and you get actually recruitment of that lung without increasing airway pressure. So that is one form of recruitment. The second form of recruitment is when your alveolus itself is collapsed or the airways are blocked, and then they have to be opened up with, depending on the physiology, how much pressure is required to open that up. I think the first part, we don't see that much in the pediatric population because the weight of the organs are not sufficiently high enough to cause collapse of the air passages. It might be in an older patient, bigger patient, but it's not so much in the 1-year-old or a 6-month-old. That may be why we may not be seeing the same kind of responses with PEEP, with similar kind of lung disease from a 6-month-old to a 5-year-old. Okay, we can now take the chat.
I think that's a good point. And if I just made, there was a point in the chat about that, which was the direct measurement of airway opening pressure using a low flow maneuver. And I think that certainly has got a lot of traction in the adult ARDS literature for the point that you're making, that this airway collapse is one of the potential major mechanisms. I've done it a little bit, and I know Bhushan Khatira has also done it considerably. And I think consistently trying that approach in pediatric patients will give us the answer of what your theory is, that this is not as much of an issue in pediatric patients.
Yeah, there is.
Do you think
I just want to caution people.
Do you think it is not an issue in pediatric because we use pressure control mode?
No, I don't think so. Recruitability should be, it doesn't matter whether you're on pressure control or volume control.
No, not recruitability, the airway opening pressure.
Airway opening pressure, yeah. So you're getting all
it is equally important. It is equally important whether you're on volume control or pressure control. With pressure control, one of the advantages is during inspiration, you may exceed the critical opening pressure throughout for a much longer time in inspiration than with volume control ventilation. One caveat I would say about the low flow technique to measure the PV curve, is the quasi-static PV curve, is the flow that they use in the adult population relative to their weight. We cannot get that low in the ventilators that we have, that we use in children. We don't have a method for them to automatically scale it down to the patient's weight to try to get a flow that low, which will simulate what you are doing with the adults. We don't have that right now.
Let us start question answer session.
Yes, sir. The first question to Dr. Robbie. This is about one of the cases which you had shared in your presentation. In your viral pneumonia case and the other case scenarios, you showed that the P-plat going up to 37 centimeters. Is that safe? Because we were asked by PALIC 2 not to exceed 28.
Yeah, so certainly not. I think the point though is that during the titration, right, it's sustained ventilation at high plateau pressure, which is the danger, but you may have to go to that pressure as part of the recruitment maneuver step, as an example. But if I leave the delta pressure at 15 centimeters of water, for example, and I go up to a PEEP of 20, if I've got a paralyzed patient and a full deceleration on inspiration, I might be achieving a plateau pressure at 35 as part of the recruitment step. You have to do that, frankly, to recruit the lung, right? But the risk is leaving it at that level for a very long period of time. So you should decouple those two concepts.
And people need to understand, a newborn baby who doesn't have any air in the lung, the first breath and the first couple of breaths, the transpulmonary pressure generated by the baby is about -40 to -60 centimeters. So the end alveolar pressure during a cry and holding it is about -40, -60 centimeters. That is required to open a lung that doesn't have air. But it's held for a very, very short period of time. That is why you don't see pneumothoraces from spontaneous breathing in newborn babies.
Next.
Okay, so we have another question, Dr. Robbie. Measuring accurate P-plat needs sedation and paralysis, which may be harmful. And measuring P-plat in spontaneous breathing child may give us P-plat, which may be equal to the PIP or higher than that. Then what's the use of measuring P-plat in a spontaneously breathing child? And won't it be harmful to sedate and paralyze each child for the accurate P-plat measurement?
I'm so happy that question was asked, because you do not have to sedate and paralyze a patient to measure the plateau pressure. I'm going to say it again. You do not have to sedate and paralyze a patient to measure the plateau pressure. In 75 to 80% of patients that are spontaneously breathing, the plateau pressure can be measured. And the plateau pressure, remember, is the reflection of the alveolar pressure at end inspiration. In a patient who is paralyzed, okay, who has zero spontaneous effort, the plateau pressure can be the same as the peak pressure or below the peak pressure. It just depends on if flow has fully decelerated during the inspiratory phase of the breath delivery. So there was a question there about, do we actually need to do the inspiratory hold if you're getting an automatic measurement from a ventilator? It just depends. It depends on if flow has fully decelerated. If you're using pressure control mode, flow is at 0, you have a slight inspiratory pause, the patient is paralyzed, then that peak pressure likely represents the plateau pressure. However, if there's an abrupt cutoff of flow, you don't have enough of an inspiratory pause, for example, then the plateau pressure is likely lower than that peak inspiratory pressure in a paralyzed patient. In a spontaneously breathing patient, it can be higher, the same, or lower. It just depends on how much effort the patient has. If the patient, think about it conceptually, right? The compliance is the compliance of the lung. So you have a patient that is breathing spontaneously. The tidal volume is, 8 mLs per kilo, right? And the patient is breathing spontaneously, and you see a peak pressure of or a delta P of 10 that's set on the ventilator. Okay. What happens, and you guys have all experienced this, I'm sure, you paralyze that patient because you want to retape the tube or something like this, right? You have to increase that inspiratory pressure to achieve the same tidal volume. Why? Because the patient was pulling some pressure into that system to generate that tidal volume. So if you do the inspiratory hold maneuver and the patient becomes passive at the end inspiration, it allows you to really estimate what the true alveolar pressure is in the system, a combination of what is being done by the ventilator and what is being done by the patient. So you should measure the plateau pressure every day on every patient, regardless of whether they are breathing spontaneously or not, and you do not have to paralyze them. You do not have to heavily sedate them. There are 20 or 30% of patients that don't tolerate the inspiratory hold. Those are the patients where you might be able to do other maneuvers, like an expiratory hold, to estimate the occlusion pressure and get a estimate of what their driving pressure or plateau pressure might be. We can talk about that another time, perhaps in that plateau pressure webinar in a few weeks.
Yeah, sure.
The only caveat I would add would be that if you're on pressure control, please try to adjust the inspiratory time so that the flow comes down to 0 before the end of inspiration.
Yeah.
There are very, very, very few clinical circumstances when you don't need to do that. There is not I would say in general, there is not a single clinical circumstance where I would like to keep the inspiratory time short enough that the flow doesn't come down to 0. Especially with ARDS, the I time is not going to be that long because they have low compliance. The time constants are going to be low. You can increase your I time sufficiently so that the flow comes down to 0, in which case you don't need to do the end inspiratory hold maneuver at all.
Yeah.
Whether they're spontaneously breathing or not, the PIP will be as close to the alveolar pressure as possible.
That's not right, Shekhar. I want to correct you there. If they're spontaneously breathing, you have to do it.
No. I'm saying if they are relaxed, then the PIP is the same as plateau pressure. But if they're spontaneously breathing, then all bets are off in terms of
Correct.
What the measurements are.
The third question is regarding which is harmful, the PEEP or the plateau pressure. So this is a long question, but I'll just summarize it. Basically, what he's trying to say is when you use a PEEP titration and you go on increasing the PEEP, suppose you are reaching a PEEP of positive end exhalation pressure of 15. So is that more harmful, or reaching a plateau pressure of 28 is more harmful? Because the PEEP itself is going to introduce a PEEP induced end expiratory lung volume and contribute to the lung strain. So which is more harmful eventually, the PEEP or a high PEEP plateau?
I think I don't know if I'm fully following the question, but
I'll take the question and then you can supplement my answer.
Okay.
If you increase PEEP and the patient's lung compliance gets better, if you're on pressure control, let's assume everybody's on pressure control, you increase PEEP, the driving pressure staying the same, the tidal volume has to improve. That means you have recruitment, which means it allows you to reduce the tidal volume so that your driving pressure is lower. Increase the PEEP again, you get an improvement in tidal volume. You can reduce the tidal volume so your driving pressure becomes smaller. You don't rely on just a fixed driving pressure to titrate PEEP. When you do the PEEP titration, once you're done with the PEEP titration, whatever improvement in tidal volume you have, you can reduce the tidal volume, which will reduce the driving pressure as well.
No, this question is not just about recruitment menu.
I know.
What is more harmful?
I know. No, what I'm saying is, but the question has a premise that is wrong. That is, you're not paying attention to what actually happens in the lung when you apply PEEP. If you have a non-recruitable lung and you keep on increasing PEEP, then the scenario that whoever has described is much more likely to happen. But if you have recruitment, then you are going to make adjustments to reduce the driving pressure while increasing the PEEP. Now, so that is the answer to the question. See what happens to the lung. See if you can reduce the driving pressure. It is not a fixed value.
Right. Dr. Khemani. The question is about the strain which is introduced by the PEEP. Is that harmful, or the plateau pressure which is there at the top, that is more harmful?
Yeah, I think
the total lung capacity versus...
Yeah, the lung strain, that is the increase in lung volume created by PEEP, can be both beneficial and can be harmful. The beneficial effect is recruitment. The harmful effect is hyperinflation. So let us say you have a lung that is not recruitable and you apply PEEP from 6 to 10, what is going to happen? The open lung is going to get hyperinflated below PEEP. That is harmful to the lung that is opened up by PEEP.
Yeah, correct. Sir, you want to say something? Dr.
No,
Khemani?
I think Shekhar handled it adequately. Yeah.
Next question is about the PEEP FiO2 table, which asks to keep the PEEP of around 10 to 14 centimeters of water at an FiO2 of 70%. However, many times in viral pneumonias, particularly in India, we have seen this. There can be an associated wheeze and bronchospasms, and the PEEP may not be very high. Also, recent pediatric study cohorts also showing the PEEP hardly around 6 to 8 centimeters of water, median PEEPs in their published studies. So how does this PEEP FiO2 table really stand? Which is
I
recommended
use
by
it as a starting point and as a guide. And I think that that's the overall point I hope that came through in the talk, is that the PEEP FiO2 table is one metric. It is an appropriate starting metric. And generally, if you should target trying to stay in line with it to avoid too low of PEEP. Okay, but within a range, it's, as you just alluded to, 10 to 14. 10 to 14 is a pretty big range, right? On an FiO2 of 0.7. What should I be doing within that range? And so I use it as the first part to say, okay, I'm mostly in line, but now I do my titrations based upon the other mechanisms that we talked about that are most relevant for the disease state of the patient. And if ultimately, in the end, you say, you know what, this patient, even though they're on 70% FiO2, have no recruitability to their lung disease, for example, and if I turn the PEEP below 10, right, to 8 or to 6, that might be completely appropriate in that circumstance, but at least you've gone through that exercise of testing it. And what happens, I think, in most circumstances is we don't always do those titrations, right? We don't do the measurement to know that this patient is recruitable or not. And so at a minimum, using the PEEP FiO2 table as a guide is a way to ensure that you're at least starting with an adequate amount of PEEP, but you don't have to live with it the entire time, right? You should be using these other metrics.
So the only caveat I would add is, historically, somehow I feel, it's possible that's not the case, I feel that both in concept and in execution, we have gone away from what used to be very sensible physiologic way of titrating FiO2. The whole goal of FiO2 management was not, just like pressures, just like tidal volumes, not to be in the injurious range, which most people considered between 70 and 100%. Try to get to about 50% or less FiO2 was the mantra that was drilled into us when we were fellows. Somehow it has gone away from that, both in the ARDS network PEEP FiO2 table, as well as in the pediatric guidelines, that somehow an FiO2 of 0.8 is okay. No, 0.8 is not okay. If you're on 0.8 and you require 0.8, generally that means your shunt fraction is quite high. If your shunt fraction is quite high, you might actually get a similar oxygenation at a lower FiO2. So one needs to reduce the FiO2 to non-toxic range, just like we pay attention to tidal volume, just like we pay attention to plateau pressure, just like we pay attention to driving pressure, we need to pay attention to FiO2 as well. And that is not there in either the adult guidelines or in the pediatric guidelines.
Thank you, sir. So, Dr. Rabi, there is a question. Should lung morphology, that's like focal versus diffuse ARDS, guide the recruitment and PEEP strategies in children using CT or the EIT?
Yeah, it's a very important question. And I think if CT scan was more widely available for our use in pediatric patients and could be done practically, because really the idea of doing it with CT guided is you have to do this recruitment maneuver and decremental PEEP titration in the CT scanner, right, to be able to see that change. And the practicality of that is very limited, even in adult units. It's only some of the best adult units that have that capability. So EIT has become, I think, the sort of newer way to be able to do this conceptually. And certainly in my practice in patients that have a significant amount of heterogeneous lung disease, it is the method that I am reaching for first. I think the challenge that remains is whether the crossing point PEEP is really always the best PEEP to pick. And I don't know the right answer to that because the slopes of those lines may be quite different. You might have a patient that overdistends very, very quickly, but barely recruits, as an example. And that's the non-recruitable patient. And so the crossing point PEEP might be the PEEP of 10, but at the PEEP of 6, it might not be very different, for example, and it might be more beneficial, to use that. So we shouldn't have dogma that the crossing point PEEP is the right answer always for them. We should be using it as a tool, to put it together with the other data that might be available, especially in patients with heterogeneous lung disease.
I would add one more thing. We
Yes.
tend to think of prone positioning as basically, okay, flat on your belly or flat on your back, right? If you have lung disease that is differential, that is one side is worse than the other, you can use the concept of the good lung being up or bad lung being up in sideways positions as well. And you will get the improvement in VQ matching similar to prone positioning by positioning the patient differently. So people don't use that approach to try to address if they have differential lung disease.
Yes, sir. So next question, for the recruitment to inflation ratio, can we drop the PEEP from 10 to 5 rather than a large drop from 15 to 5?
Yeah, it's a good question. I don't know the answer to that. Theoretically, it is two large step, a large step in between is what is relevant. And all of the, adult trials have really focused on this 5 and 15 as the fundamental difference. So I would say I don't know yet. Theoretically, yes, if you have two reasonable steps, maybe you can do this, but I think that needs to be validated.
But there is an assumption behind all those studies that do the 15 to 5, the inflation ratios, that all these lungs have the same critical opening pressures. They don't. They have so many different opening pressures. And therefore, if you go from 15 to 10, some of them will collapse. If you go from 15 to 5, more of them will collapse. That's it.
That's the whole thing, yeah. The next question is about the PEEP titration. Actually, what the question is, when you increase the PEEP, you are increasing the mean airway pressure, and oxygenation will anyway improve. This we have already discussed, because the blood entering into the shunt will reduce, and Henry's law, and that's why you need to monitor carbon dioxide elimination also. But then when you're doing a PEEP titration and you're increasing the PEEP incrementally, how do you monitor live carbon dioxide elimination? EtCO2 may not be reliable, because sudden improvement in EtCO2 may not necessarily that the carbon dioxide actually elimination is improving.
Robbie?
So,
yeah, I mean, I think it again, I don't do it on the recruitment step, right? It's on the decremental PEEP titration that becomes relevant. And really fundamentally, if you are trying to identify, depending on the heterogeneity of the lung disease, right, will dictate this. But if compliance is best, theoretically CO2 elimination should also be best at that point, right? And so if you're using a pressure control method on the way down, you're really looking at the point of the best compliance. If you're using a volume control method on the way down, you're looking at the best sort of driving pressure. And theoretically, compliance and CO2 clearance should align with one another. Now, that might not be entirely true in some circumstances, like we've talked about with significant heterogeneity in lung disease, but that's why I don't, for example, do blood gases at each step, because I'm really looking at lung mechanics as my metric. There are some ways that you can use the capnography-based markers. So end-tidal CO2 still has utility if you're using pressure control in the reflection of CO2 clearance and the drop in tidal volume, right? But you can also use like things like ventilatory ratio or ventilatory efficiency. These are still sort of experimental, I would say, in nature, but they might be a way to avoid having to get a blood gas at each level to look at the dead space fraction. Alternatively, you measure the dead space fraction at each level with the blood gas.
Right. So the next,
I would say I agree that you do the titration based on lung compliance. If you really don't have an improvement in lung compliance, there's no point in measuring the other things.
no, but
For
sometimes the
recruitment.
lung compliance
No,
also.
I'm saying for recruitment. If you want to know if you have recruited the lung, if you don't have an improvement in lung compliance, don't bother with the other measures. But let us say you have done a recruitment maneuver and you found the best compliance point and you set your PEEP based on that particular thing. Then you wait for steady state and see what your end-tidal CO2 is. One assumption you can make at the clinical bedside is you know your arterial blood gas prior to the recruitment maneuver. So you know what your arterial value is. If you have good recruitment, that arterial value is not going to go higher than that. It'll go either stay the same or go lower.
Low.
Now you look at your end-tidal CO2. If the end-tidal CO2 actually goes higher, that means there is more CO2 being eliminated. So if you assume that the arterial CO2 is going to stay the same, then the difference becomes smaller, which is less dead space. If perchance the alveolar, the arterial CO2 also goes down, then it will become even narrower. Then you have less of a physiologic dead space. So I would say the change in end-tidal CO2 becoming higher in steady state after you figure out the best compliance point with a PEEP titration or whatever recruitment maneuver you're going to do.
In a set minute ventilation mode. Correct. In a VC or PRVC mode.
And you should not change the mode while you're making the steady state measurements.
The next question, I think we can, Dr. Robinder can answer very quickly. This is somebody is asking that we have done a randomized control trial of a PEEP FiO2 versus PEEP titration. Results are still under review, but we found that in both the groups, the PEEP turned out to be same because the PILIC2 restricts us not to go with a PEEP plateau above 28 and the driving pressure should be kept below 15. So ultimately, we ended up having same PEEP in the both arms. So what do you have to say?
Fascinating. That's great. I think that the truth is this is highlighting the challenges of taking ideas and translating them into randomized trials, right? And this is often what happens in randomized trials is we merge to the same and we don't actually have separation of the two treatment arms in the way that we approach them, especially with usual care. You've highlighted the real challenges of doing randomized trials. That's not to say, however, that just because you have no separation sort of between groups in the randomized trials, that you can't learn from that information. And I think this is increasingly where we're moving towards secondary analysis of RCTs is to understand individualized patient-related heterogeneity of treatment effect, because what you're highlighting there is that the global values are the same, right, between the two groups. But there still is individual variation on the patient level, and there may be certain types of patients that would have benefited more from the PEEP FiO2 type approach versus the more usual care approach. And that's where I think, we can go to understand even negative or non-separated randomized trials.
It also illustrates the misconception that people have with PILIC2 guidelines that they are prescriptive. It only says guideline is try to keep the plateau pressure less than 28 centimeters. Doesn't mean that if you go to 29 centimeters, it's a life and death matter that you are committing a big sin. It's not. It is a guideline to say if you stay below 28 centimeters, if you can't stay below 28 centimeters, it's safer. That's all it says. It doesn't say that you have to be below 28 centimeters.
Yeah, that's right.
Next question.
Especially when the
So-
level of certainty of evidence is very low for almost all of those. Yeah.
Next question to Dr. Robbie. How long does each step of the recruitment manual take? And I mean, how long he wants to ask, how long do we need to wait?
Yeah, so that's a hard question to answer because it's a practical balance too, right? You can't be sitting there at the bedside for like 2 hours to do these recruitment maneuvers. Nobody has the time, right, to be able to do that. So really on the step up, I generally spend two minutes or so at each step because the only goal on the step up is again to make sure that the patient is tolerating it from a hemodynamic standpoint, as an example, right? So I want to go a little bit slowly on the way up to ensure that I'm not going to cause harm, right? And then once you get to that final recruitment step, I stay at that step for 3 or 4 minutes if I can, if the patient is able to tolerate it hemodynamically. And from a hypercarbic standpoint, they're not getting too hypercarbic. And then the step down is 2 to 3 minutes at each step. You want stabilization in the tidal volume and compliance value. And typically 8 to 10 breaths, you actually get stabilization. But as Shekhar kind of alluded to, there are some patients where it may take up to 20 breaths or so, which is why 2 to 3 minutes at each step is really what I will do on the way down. And I think that yields a practical recruitment maneuver in PEEP titration that can be done in 15 minutes or so. When you're having to go 30 minutes an hour, like the conditions of the patient might also change, in that process.
Yep.
There are studies that show how the lung actually increases in volume, both just inflation of already open lungs and recruitment. The inflation of already open lungs happens within a few seconds of you changing a PEEP level or doing a recruitment maneuver, because that is a lung that is already open and the volumes are going into that lung much faster. The recruitment happens over the next, in some experiments, about 2 to 3 minutes. Like Robbie said, about 2 to 3 minutes. What you can do is you can actually see at the bedside whether the tidal volume stabilizes. That is individualized per patient. Once the tidal volume stabilizes and you have 10 breaths that have very stable tidal volumes, you can go to the next step. I don't wait for 20 breaths. It might happen within 5 breaths that they are stable and then the next 10 breaths are stable. You can even reduce it to 5 breaths. 5 breaths that are very stable tidal volumes, and then you go to the next step. It doesn't take long for the stability to happen with one step. And the same way, on the way down, you will have initially a change in volume, and then it'll stabilize. So you wait for the stable tidal volumes to appear, then you can make it 5 or 10 breaths after that.
Okay, so I have a follow-up question to Dr. Robbie on this then. So because Dr. Shekhar sir is mentioning this technique, so do you agree with this? Because there are two different ways now, what Dr. Shekhar and Dr. Robbie are saying.
Yeah, so frankly, 6 to 8 breaths is generally adequate. And 6 to 8 breaths is what I do as my minimum. And then if there is stability, you can move on. If there is not stability, then you wait until there is stability, up to generally 20 to 30 breaths. On average, it's about, you can wait up to 2 minutes at each step and still be able to do this kind of practically and accomplish both, right? Both ideas there.
Thank you. So next question, Dr. Robbie, how do you approach PEEP titration in a patient with significantly asymmetric lung disease?
Yeah, I think we talked a little bit about this just to sort of at the high level, right? Is that it's still the same concept of you're trying to balance, the regional differences and how much recruitability you're going to get. It might be that, as Shekhar alluded to in that talk, in his slides, if you've got asymmetry because one lung is atelectatic, right, then I might benefit with recruitment, right? If I can open that additional lung and I compromise the healthy lung for the period of recruitment, and then I actually open that lung, it's recruited, and now I'm more homogeneous in the balance. The challenge is if that lung is very consolidated and not recruitable, right? Then as I go through that process, what I might just see is I'm just over-distending the healthy lung. And then the balance point that you lay at is you just accept that the more injured lung is consolidated, and I'm not going to apply a high PEEP. I'm going to keep the PEEP low in that circumstance. You still get a measure with global mechanics, but the EIT-based approach is, I think, even more valuable there to understand it when you have that regional difference.
Dr. Faz.
Yes, so the next question is, do you think electrical impedance tomography could be useful when the patient is on NIV?
Maybe. So there, yes, there can be uses for it, right? We've done some studies with EIT for patients on high flow nasal cannula, as an example, and you can see as you titrate and adjust the flow, you see changes in end expiratory lung volume, you see changes in tidal impedance. So in that same way, you can think about applying that to NIV. It's not going to be useful in the same way. And what I mean by that is you can't do this PEEP titration with this, recruitment maneuver decremental PEEP titration, creating that curve of overdistension and collapse, because you have to have steady conditions for that to really be able to work. Do that recruitment maneuver, look at those big changes to be able to identify that. But the advantage of EIT is you're normalizing to each patient's prior condition. So when you're looking at 2-3 conditions, right, I might try a low EPAP, gradually increase the EPAP. You can see, was there an improvement in end expiratory lung volume, as an example? Was there improvement in tidal impedance? Was there an improvement in regional ventilation? But you're just not going to get that curve.
Right. The next question is, do we need to do an inspiratory hold to measure plateau pressure at each step of PEEP titration? When you're increasing the PEEP or when you're coming down, at every step, do you do an inspiratory hold to measure the PEEP plateau?
So it depends on how you set the inspiratory flow, right? Or how you set the inspiratory time. So if you've got a paralyzed patient and they're passive, for sure, and you set the inspiratory flow to have at least a flow pause of 200 to 300 milliseconds, I think you probably don't have to do the inspiratory hold on the way down. You can rely upon that value as a as your surrogate, as your measure, basically, for the static compliance. We have a paper we just recently published that looks at the duration of the hold that's necessary to get an accurate determination of the plateau pressure. And in a passive patient, in circumstances where airway resistance is not high, 200 milliseconds is fine. 200 to 300 milliseconds is fine. In an active patient, okay, so not a paralyzed patient, you may need 500 to 500 milliseconds to 1 second, sometimes even larger when the respiratory effort is very high. So if the patient is active, then you absolutely have to do a true plateau pressure. If the patient is passive, flow decelerates, you have an inspiratory pause, airway resistance is not high, then you can probably rely upon that value.
Thank you. So thank you so much, both Dr. Robbie and Dr. Shekhar, sir. So over to you, Dr. Khemani.
There is a question there. I think the person asking the question has a misconception. So I think it would be best to clear that misconception.
Which one, sir?
So the adult data suggests that in severe ARDS, optimal P-plat is 28 to 32 centimeters. That is a wrong conception. The guideline is not to exceed 28 to 32 centimeters. Doesn't mean that 28 to 30 centimeters is the optimal value. optimal value you need to keep in your mind is the one that causes the least amount of injury.
I think
that might be 15. That might be a plateau pressure of 12. That might be a plateau pressure of 13. It only says that please don't exceed this value because we think the injury to the lung is more when you exceed this value. So the word optimal should be taken out. The guideline is 28 to 32 centimeters.
Upper safe limit, yes.
And the other question is the end alveolar pressure same as plateau pressure? I think Dr. Khemani explained it beautifully when it is the same and when it is not the same.
Thank you very much for clarifying that, Dr. Shekhar. Quickly, as some of our participants are leaving, if you have a moment, I'd like to entreat you to go into the chat and fill out the survey so we get a sense for how we're doing and how we can get better. In any case, this was a real treat. I want to thank Drs. Robbie and Shekhar for such an insightful, spirited, and actually brilliant discussion on so many of the things that are practical and really important to those of us who are managing sick kids with bad lung disease. And then the final thing is that I want to alert you that next month we'll be carrying on these sessions. On August 20th, we'll be talking about driving pressures and lung protective ventilation in the PICU, and we'll have as our expert Dr. Anil Sachdev joining us. And you know, these monthly sessions carry on, and I think those of you that are here are really benefiting from the kind of talk that we get from these experts and the questions, and it's interesting and entertaining all at once. And thank you all for joining us.
Thank you so much, sir.